Hi, I'm Casey Walker. I'm an attorney with the VA Disability Group. Today we're going to discuss the shoulder and arm C&P examinations. I'd like to give you an overview as to what you can expect at a C&P examination and some of the important considerations. As we get into this discussion, I'm going to bring up some of the important regulations that you should be aware of. And I'm also going to point out some of the rating criteria that you need to focus in on and be competent of as you go into the examination. So let's get right into it. We're going to discuss, well, there's so many shoulder conditions, but I'm going to focus on the primary ones that we see often. I can't discuss every shoulder condition under the sun. That we'd be here all day. But we're looking at shoulder strains, shoulder sprains, arthritis, bursitis. Sometimes people have shoulders come in and out of socket, dislocations, shoulder replacements, and clavicle injuries. Those are going to be the ones I'm going to try to hone in on for the C&P exam discussion today. If I don't discuss your specific topic, hopefully I can get you into the correct area and regulations where you can at least look into something for yourself. So let's talk about 38 CFR 4.71. Now, what you're going to find here is this is the schedule of ratings. This is the regulation that dictates what type of evaluation you're going to receive from the VA. Now keep in mind that assumes you've already been service connected. The scope of today's discussion is assuming you're going to be service connected. It's how to get the right evaluation assigned. So 4.71, 38 CFR 4.71 is going to be the controlling regulation for evaluations assigned for the shoulder. Let's also take a look at 38 CFR 4.59. Now this one's quite important, and I'll dig into it a little bit more as we get into this, but this 38 CFR 4.59 discusses painful motion. The VA, this regulation specifically, right in the middle of it says, and I'll just read right from it, it is the intention to recognize actually painful, unstable, or malaligned joints due to healed injury as entitled to, and here's the important part, at least the minimum compensable rating for the joint. So that's a fancy way of saying that if you have painful motion, you're going to get an automatic 10 or 20% depending on the joint. Incidentally, for the shoulder, usually the lowest it goes is 20% for the shoulder joints. So if you just say ow and you have an injury and you have a little pain and you communicate that to the examiner, you should get a 20% for that respective joint. Let's also take a look at 38 CFR 4.46. Now, the purpose of pointing out this regulation is a lot of your examiners take shortcuts. Not all of them, but a lot of them take shortcuts and they don't take the measurements properly. You'll notice in this regulation that it says the use of a goniometer in the measurement of limitation of motion is indispensable in examinations, which is another way of saying it's required. So if you go to a C&P examination, sometimes they knock out 5 or 10 joint exams in a matter of an hour. That's not possible. And what that suggests is they're not using a goniometer. It's kind of like a compass tool that allows just measurements of joints to be determined. It's a measuring tool with different degrees of motion that you can put the compass tool or the goniometer right up to the joint. So if they don't use that and you get bad evaluations, then you're going to want to send a communication or a letter to the Evidence Intake Center in the VA or the BVA communicating that you don't believe your examination was done properly because they didn't use a goniometer. Only do that if you get a bad result. Don't send that letter in unless you know you get a bad result, because you don't want to hurt a good result. You don't want to cast some type of doubt onto the efficacy of the exam if it was done improperly, but you get a good result. Only wait for the examination determination and that rating decision before you send a letter. Next, we're going to discuss 38 CFR 4.71. The point of this regulation is more pictorial. Every joint has different types of flexions and extensions and bendings, and they use certain terms to describe those types of maneuvers of the joint. And here you get actual pictures so you can see precisely what they're describing. Now, we're talking about the shoulder, so let's take a look at the shoulder. You'll notice the shoulder gives the flexion and shoulder abduction. They also show you the shoulder external rotation and internal rotation. But we're only going to really focus on the flexion and abduction because 99% of shoulder examinations and evaluations are based on the flexion and the abduction. So those are going to be the top two. Now that we've discussed the regulations you want to be familiar with and some of the terms or ranges of motion that you need to be familiar with, let's take a look at the actual diagnostic codes within the rating schedule and the rating criteria for those conditions. And then once we're done looking at some of those specifics, we'll turn to the Disability Benefits Questionnaire or Examination Report so that we have a better idea as to what the examiner is going to be looking at. And you'll notice a trend that the regulations are all over the examination report. So let's turn to 38 CFR 4.71a. This is the one we looked at earlier. And we're going to go down to Diagnostic Code 5201. Now you'll notice here we're in the shoulder and the arm section of the musculoskeletal joints. When you go to 5201, about 90% of shoulder evaluations are assessed under Diagnostic Code 5201 because that includes your strains, your sprains, your arthritises, and your bursitis. Those are the most common things that the VA is going to assess. And it's all going to be under Diagnostic Code 5201. Now you'll notice under Diagnostic Code 5201 that you have two different numbers. You have a 40 and a 30 and a 20, and a 20 and a 20 at the bottom for each respective degree of symptoms. What those are major and minor extremities. So if you're right arm dominant or right-handed, that's going to be your major dominant extremity. So that's going to compensate better than the minor extremity. So if you're left-handed, that would be your major. If you're right-handed, that would be your major. And so the VA has parsed out the right-hand dominant versus the left-hand dominant, and you're going to get a higher evaluation in some instances if it's your dominant extremity that's affected. Now you'll notice here that the limitation of motion for flexion and or abduction to 25 degrees from the side is 40 and 30% depending on major or minor extremity. Now keep in mind, that means you're only going to about here. That means that you can barely move your arm in any direction. I've never seen someone really with that much limitation unless they got out of a shoulder replacement surgery. You don't need to oversell the limitation of motion. It's exceedingly rare someone can only move their shoulder 25 degrees. 45 degrees is only halfway. This is 90 degrees. If your arms out to the side are 90 degrees. So when you go in for this exam, most people who are really disabled can still get their arms up to 90 degrees. Well, 90 degrees is the minimum compensable rating, which is 20%. So this is a long-winded way of telling you pain alone is all you need to get that 20%, because they're only going to give you 20% for the limitation of motion or pain. Well, most of us have pain in the shoulder if you have a shoulder condition. So just make sure the examiner knows that you have pain, and you're going to get that minimum compensable evaluation under 38 CFR 4.59. That's a regulation we looked at a little bit ago. That's what you need to know. All right? So 20% is for pain. We'll now point that out on a DBQ as we get there. Let's take a look now at the next diagnostic code. We're going to look at 5202. And you notice here we're looking at the humerus other impairment of. So really what you're getting at here is you're looking at dislocations. Your shoulder's out of socket. I remember I had a friend in football when I played high school football, and they would always pop his shoulder and back into place in the middle of the game. But if you know someone who has a shoulder that pops out of socket, it can become a problem when they're doing athletic things. But that's what 5202 is really getting at here. And you'll notice we have different evaluations, and this stuff gets a little complex. But the important thing is they use this term non-union and malunion. So let's discuss what the difference is between malunion and non-union. A non-union is a fracture or bone break that doesn't heal, and a malunion is a fracture that heals incorrectly. So a non-union is going to be worse because it doesn't heal at all, whereas a malunion is kind of it's not formed properly, and you can physically see a malunion at times because it looks deformed. So those are the two legal terms of art we need to be familiar with. Now, when you're looking at Diagnostic Code 5252, you'll notice they use the term non-union of, and they say false flail joint. They'll also say malunion of, and they say marked deformity, moderate deformity. So they use these terms. The important thing is that you need to be prepared on the day of the examination to communicate to the examiner that your shoulder pops in and out of socket in and out of socket, and you have the frequency of those episodes. Now, you might not have that medically documented. A lot of people's shoulder pops out of socket when they're not at the doctor. But statements from friends and family will help support the frequency, which is important in this diagnostic code. So we're talking your shoulder kind of falling in and out of socket. Moving on from there, we're going to look at diagnostic code 5203. This is getting into the scapula and the clavicle. Sometimes people fracture their clavicle. That's kind of where we're at here. You're looking at non-union and malunion. Those two terms are used again there. And what's interesting here is the first time we see a 10% assigned in the arm and shoulder region, but this is specifically for the clavicle. So if you have a clavicle injury that you have pain on, you might get a 10% instead of the 20%. But if it's anything other than the clavicle or scapula, then you should be in the 20% range with pain alone. Lastly, we're going to take a look at diagnostic code 5051. This is for a shoulder replacement. You don't see a lot of shoulder replacements, but if you have a shoulder replacement, it's going to be 100% for 1 year guaranteed. And then following that, we're looking at residuals, and they're looking at weakness, pain, or limitation of motion. There will also note here that the minimum evaluation for the shoulder following a replacement is 30% for a dominant extremity or 20% for a minor extremity. So at a minimum, they have to give you 20 or 30%, depending on the arm that's injured or the shoulder that's injured. But 100% for 1 year, then they're rating the residuals with a minimum of 30 or 20% respectively. One other consideration we want to discuss is this 20% minimal compensable evaluation is applicable because of a landmark case known as Johnson versus Shinseki. And what the VA used to do is they would take that 38 CFR 4.59 and they would apply a 10% evaluation as a minimum compensable evaluation for joints. But the attorney for the veteran argued, and the veteran argued, no, the regulation says for that joint. And they argued successfully. So you can thank that case and that individual, that veteran, for arguing that, because all veterans after that case get 20% for a shoulder condition other than the clavicle or scapula if they have pain. Okay, so now let's take a look at the actual disability benefits questionnaire. Again, this is one, the DBQs are public facing, meaning you can print these and bring them to your own medical provider. The VA compensation and pension examiners use this exact same form. It might look a little different, but the same substantive information is on it and the same check boxes are on it for those examiners. So this form's critical. This is what dictates the type of evaluation you're going to get. And it mirrors the regulations we just looked at. So some of that should start to make sense as we walk through this DBQ. So let's take a look at it. Most of these DBQs follow a similar format. They call them SOAP notes, which is subjective complaints. And then you get into the objective findings, which is the examination. Then you have the diagnosis or assessment is what A stands for. Then lastly, P would be the plan. What type of medicine are we going to give the patient, and what's the maybe rehabilitation. So it kind of follows a similar SOAP notes. Starting with, we're going to start with the diagnosis, which is going to be the assessment. The examiner has to determine, does this veteran have a condition? So you need a diagnosis, but we're talking about the examination here, so we're going to assume there's a diagnosis. Moving on to section 2, we have the medical history. That's where the examiner just becomes a scrivener. They're just going to write down, fell, hurt himself, has been complaining ever since, shoulder allegedly comes in and out of socket routinely or something like that. Moving on from there, we're going to look at section 3. This is the important part. This is where you're getting into the range of motion testing. As I mentioned earlier, it's exceedingly rare that people get good evaluations for limitation of motion on the shoulder because it's so extreme. But what you'll also find in section 3 is this is where they also ask if there's pain. And we're going to go right there. At the bottom of page 4, is there evidence of pain? Yes or no? That's it. They check yes, and they check one of the boxes of where pain's demonstrated, then you should get the minimum compensable evaluation under Diagnostic Code 5201, which will be 20%. So that's where they'll demonstrate the painful motion on the examination report. You'll notice there's another section that says, did you repeat the motions, multiple repetitions, did the symptoms get worse? And a lot of times the examiners just say no, but as long as they check somewhere that you have painful motion on this report, you'll be good. Moving on from the painful motion, you'll notice in section 4 that we get into muscle atrophy. Section 5 is ankylosis, and section 6 are rotator cuff injuries. You can look at those on your own, but they are different symptoms that can be compensated differently. Moving on to section 7, which is the clavicle and scapula that we discussed earlier. That's going to be under Diagnostic Code 5203. You're going to see the exact language that we already looked at. Malunion of clavicle, non-union of clavicle or scapula, dislocation. So those are directly from the Diagnostic Code. So just ensure that the respective boxes are completed if you bring this report to your medical provider. Moving on from there to section 9, which is going to be the impairment of the humerus. And yet again, you'll notice that you have the exact language coming directly from the regulations. Marked deformity, moderate deformity. Do they have a flail shoulder with non-union? So those are directly from that Diagnostic Code into regulation. Moving on from section 9, let's take a look at section 10, surgical procedures. This is where your shoulder replacement will be documented. If you had a shoulder replacement, you need to ensure that they document the replacement in section 10. And the date that they usually put that the surgery happened, that's the starting point for that 1 year at the 100%. Right here, date of surgery, section 10, that's usually the date that the adjudicator or judge will determine or assess your 1 year mark. Then they usually bring you in for another examination to determine the residuals. And as we discussed earlier, that will be a minimum of a 30% if it's a dominant joint. That's really, there's a lot of other sections here, but that's really the critical parts of this disability benefits questionnaire. Let's talk about some of the unique considerations when considering the shoulder joint. I've kind of hit on this multiple times, but painful motion. So ensure that they see. Give a little wince, give a little ow. It's not a day to be a tough guy when you go in for this exam. Let them know that you're hurting so that they check that painful motion box. As I mentioned, it's very difficult to get an evaluation assigned if you have limitation of motion because it's so extreme. So don't try to sell it. Be credible and just let them know that you're hurting, and that alone should get you the exact same evaluation, which is 20%. If you have a lot of dislocations or your shoulder pops in and out of socket, you want to get statements from people who have observed this. I gave the example earlier of a football coach who would pop my friend's shoulder back in the socket. But if you see someone who, if you have a lot of shoulder dislocations, you're going to want to get statements from anyone who's observed that, and you're going to want to send that to the VA and maybe bring them into the examiner as well so they can see those statements, because if you recall, the frequency of those dislocations is critical. So you need to demonstrate that the frequency is great. Lastly, if you go into a shoulder exam and the examiner did not use the goniometer, which is the measuring tool, and you get a bad evaluation, send a note saying that the examiner did not use a goniometer. Hopefully that alone is enough to bring you in for another examination. It might take a bit, but you might get down to a judge and a judge sees your note and says that you need a new exam so that the examiner can use a goniometer. So that's what we have today on the shoulder C&P exams. I hope you found this helpful. There's a lot to cover in the shoulder. It's more complex than a lot of the joints. I hope you found it useful. If you did, like and subscribe to the channel. Thanks for watching.